Years ago, premature babies died of lung disease. Their lungs were so immature that their smallest little air passages, known as the alveoli, would collapse after birth, and the babies couldn't breathe. And putting them on ventilators made the lung injury even worse. But over the years, neonatologists learned a lot about treating the lungs more gently, ventilators got better, and a molecule known as surfactant was discovered, which could be instilled into the lungs to protect the lungs from injury. And with that therapy, many of these babies lived several weeks longer, only to develop a severe disease of the intestines known as necrotizing enterocolitis, or NEC for short, as I'll refer to it during this talk. Premature babies are the smallest, most fragile, and most vulnerable patients that we take care of in the hospital. I would like to ask each of you to look down at the size of your hand. Imagine a baby who's born no bigger than the size of your hand. A baby that's so premature that it has to be kept in an incubator to survive and stay warm, and its skin is so thin that it's translucent. Whereas the intestines of a full-term baby can tolerate handling feeds, the intestines of these premature babies are so immature that they're predisposed to developing this disease of NEC. NEC was initially identified and reported in the 1960s, and it affects approximately 10,000 premature babies in the United States each year alone. Despite 6 decades of research, the morbidity and the mortality of the disease remain unchanged and is up to 50%. This slide depicts the typical appearance of a baby with NEC. You can tell from the number of lines, tubes, and drains that are in place that the baby is quite ill. The abdomen is distended, and there are several loops of dark and discolored intestines which are afflicted with NEC. And hopefully there are some viable loops of intestine as well. The only therapy for these babies at present is to put the intestines at rest by withholding feeds, inserting a nasogastric tube into the stomach to suck out the enteric contents, and to administer very strong antibiotics. And with that medical management, many of the babies will get better. However, many of them will continue to get worse and will require surgical removal of the intestines. However, even with surgery, the morbidity and the mortality remain extremely high. Just as a molecule known as surfactant was discovered to protect the lungs of these premature babies from injury years ago, it's my hope that we can identify a therapeutic strategy to protect their intestines from injury as well. In 1989, I performed my first operation for NEC. Baby boy Lewis was born at less than 2 pounds in size, which in those days was really quite small. We operated, we removed the injured intestines, and he lived and survived, and we all congratulated ourselves. But many babies with NEC aren't that lucky. As a practicing pediatric surgeon here at Nationwide Children's Hospital, if I'm on call tonight and end up with a consult on a baby with NEC that goes on to require surgery, I need to tell the parents that there's only a 50% chance that their baby will survive. And to me, that's completely unacceptable. That is the sole motivation that has prompted me to spend my entire academic career searching for a cure for this disease, which will allow us to never have to operate on these babies again. In the late 1980s, I discovered a growth factor known as heparin-binding EGF-like growth factor, or HBEGF. A growth factor is simply a protein that stimulates cells to grow or to proliferate and to move or to migrate. And the growth and the movement of cells is very important in wound healing, including wound healing of the intestines. In 1991, we came to Nationwide Children's Hospital and established the Pediatric Surgical Research Lab. For many years in the lab, I've had an animal model of necrotizing enterocolitis that allows us to test the efficacy of novel potential therapeutics for this disease. And we found very early on that if we simply added HBEGF to the feeds that we were giving to premature animals, we could protect them from developing NEC. Well, we were really excited about that finding, and we went to the Food and Drug Administration and asked them for permission to begin phase 1 clinical trials of NEC in premature babies at high risk of developing the disease. After many conversations with the FDA, we actually did get approval to begin phase 1 clinical trials, but rather than doing these on premature babies, they insisted that we do it on healthy human adults first. Well, HBEGF is very expensive to produce, and to give it to healthy adults would take a huge amount of the growth factor. And it's very hard to find funding for those types of phase 1 studies, so we haven't started those studies at present. And in addition, although growth factors are very beneficial in terms of wound healing, they've also been implicated in tumor formation, and we certainly wouldn't want to save the life of one of these babies only to have them develop a malignancy later on. So we next turned our attention to stem cell therapy. Stem cells are very primitive cells that have the ability to differentiate into all of the different types of cells in the human body. We found in our animal model that we could administer stem cells and also protect the intestines from NEC. However, stem cells have also been implicated in tumor formation and may raise the same concerns at the level of the FDA as with growth factors. So it became apparent to me that in order to treat vulnerable and fragile patients such as these, we needed to change direction. And we needed to find something that would be regarded by the Food and Drug Administration as generally recognized as safe, or GRAS. So most recently, we've turned our attention to probiotic therapy. Probiotics are beneficial health-promoting bacteria. They're extremely inexpensive. They're generally recognized as safe by the Food and Drug Administration. You can get them in many different formulations by walking into any health food store, or you could simply eat a lot of yogurt. So why are we interested in probiotics? Whereas full-term babies have intestines that are colonized with health-promoting probiotic bacteria, the intestines of premature babies are colonized with pathogenic, harmful bacteria associated with NEC. It's our hope that we can administer probiotics to those premature babies to rid their intestines of the harmful bacteria that lead to NEC. Well, we've become very interested in a bacteria known as Lactobacillus reuteri, and several intensive care units across the country have already begun clinical trials of probiotics in premature babies in an effort to protect them from NEC. However, the results have been very variable, and probiotics have some problems associated with them. They have to be administered in very high amounts. We need to give repetitive doses of the probiotic in order to get any kind of a clinical effect. And some reports have surfaced of bacteremia associated with the probiotic that was administered. Well, bacteria are pretty smart. And pathogenic bacteria have the ability to secrete a protective film around themselves called a biofilm. Most physicians think of biofilms as our enemy because they prohibit antibiotics from getting to the site of infection. The novel and unique aspect of our research is that we've figured out a way to make these probiotic bacteria secrete a biofilm so that they can be protected as well. All clinical trials to date have included administration of the free-living form of a probiotic. Dr. Steve Goodman here at Nationwide Children's Hospital has figured out a way to take Lactobacillus reuteri, to adhere it to the surface of microspheres, and to stimulate it to form a protective biofilm that preserves the integrity of the bacterium. Even better, we can fill those little microspheres with beneficial substances that can protect the bacteria further and make even more biofilm formation. So on the left, what we're looking at are several probiotic bacteria adhered to the surface of a single microsphere. And you can see some biofilm formation as shown by the green staining. On the right, We've filled those microspheres with sucrose, which is common table sugar, and what could be accepted as more generally regarded as safe by the FDA as compared to table sugar. And you can see even more biofilm formation. We find in our animal model that if we administer Lactobacillus reuteri on sucrose-loaded microspheres, we can prevent even the most severe forms of NEC with just a single dose administration. So rather than thinking of biofilms as our enemy, we prefer to think of biofilms as our friend. Now, if I took your intestines and stretched them out lengthwise, they would be 10 feet long. Many babies survive NEC only after the surgeon has resected a significant length of their intestines, and they can be left with intestines that are only this long. These babies can't nourish themselves by mouth, and they have to survive with the administration of total parenteral nutrition, which is high-calorie intravenous feeds. These babies can spend months to the first year or more of life in the hospital. Imagine a baby spending more than a year of their life after birth here in the hospital rather than at home with their family. Intestinal transplantation is an option for these patients, but the results are not so great, and these patients would then require immunosuppressive therapy for the rest of their lives so that they don't reject the transplanted intestine. Another option for these patients would be the production of tissue-engineered intestine, and this is how it would work. A patient with short bowel syndrome receives either an endoscopic biopsy or a stomal biopsy of a tiny little piece of their intestine, similar to the end of your pencil tip. That tiny piece of intestine is then grown and expanded in the laboratory multiple times. And it grows in the form of little structures called enteroids. Those tiny little intestinal enteroids can then be used to seed a biodegradable scaffold. The seeded scaffold can then be implanted into the abdominal cavity of the patient with short bowel syndrome, and after several weeks, the intestine matures. And once it's matured, it can be anastomosed or sewn in line with the patient's short length of intestine to effectively lengthen the intestines of the patient. And we've been able to do exactly that in our laboratory. On the left, you see the appearance of normal rodent intestine, and on the right, you see the appearance of tissue-engineered intestine that we've produced in the lab, and you can see that the histologic structure under the microscope is virtually indistinguishable between the two. So it's our hope that someday in the future, we can use tissue-engineered intestine to treat patients with short bowel syndrome. Well, it's been 27 years since I operated on baby boy Lewis, and unfortunately, we're still operating on these babies. But I have great hopes, and I remain optimistic. And I hope that with novel therapeutic strategies, such as our novel probiotic delivery system, we can prevent babies like this from developing necrotizing enterocolitis in the future. Thank you.